We will now begin with the session one on regulatory deficit and access to healthcare. Kindly be seated. The panelists that we have for this session, Mr. Vikas Kathuria, Associate Professor, BML Munjal University, Suresh Prabhu, Founding Chancellor, Rishihut University and former Union Minister of India, Mr. Simon Conan Coffey. He will be joining us virtually. Regional Competition Policy Approach for Access to Healthcare Executive Director, ECOWAS, Regional Competition Authority. Then we have Mr. Hardin, Competition and Access to Healthcare, Commissioner, Competition Commission of South Africa, Mr. Milan Andani, Price Control versus Competition Leader, Pharma and Life Sciences Practice and Social Sector Practice, Ms. Rashid Desai Associates India. He'll be joining us virtually. Then we have on the panel who will be joining us virtually Ms. Archana Jatkar, IT Border Measures and Access to Drugs, Associate Secretary General, Indian Pharmaceutical Alliance, Mr. Samir Kulkarni, Head Regulatory Biosimilars and its Impact on Competition, Department of Biological Sciences and Biotechnology, Technology Institute of Chemical Technology, and Ms. Lisa, Pro Competition Intellectual Property Policy Global IP Advisor, Access Campaign. Thank you.
All right, good evening, everyone. So, welcome to the first session of the event, Regulatory Deficit and Access to Healthcare. Well, the pandemic has demonstrated the importance of this sector where innovation and access are equally important. I come from academia, so I'm just going to quote one academic, Dr. Philip Lowe. He says that pharmaceuticals and healthcare is a sector where dead weight loss turns into dead bodies. It's a profound statement. And with this note and against this backdrop, I would invite the speakers to come and share their thoughts about access, about the difficulties they are facing, and that will be food for thought for us. Thank you so much. Without taking up much time, because we are already running behind the time, I would like to invite our first speaker, Mr. Simon Conan Coffey.
Yes, thank you for the opportunity given to me, share with you the experience of the ECOWAS region regarding regulatory deficit in access to health care. I think this is section 1. Regarding the health situation in the ECOWAS region, as I mentioned earlier, I think the region is facing so many challenges regarding the healthcare situation. You have so many outbreaks, so many communicable diseases. I think based on that, most of the countries have taken some measures that are not always in line with competition rules. But the issue of public interest is putting forward to be able to address the health situation in the countries. What you have noticed is that the major policy issues with respect to health and pharmaceutical sector is that these areas are highly concentrated. You have a few number of players, and these players are also rely on import to cover the domestic demand. And these sectors are highly regulated. And for instance, the impact of regulation in preventing entry into the pharmaceutical sector and drug industry is very pronounced in many countries of the ECOWAS region. There are a delay and high cost involved in the registration of product and acquiring certification, so which doesn't allow new players to easily enter into these sectors. You have also a high cost of registration of a product. And the registration fees is quite high. That discourage so many new players to, let's say, embark on in this health and pharmaceutical sector. This one is a deficit of regulations that we can also highlight in many countries. We can also notice lengthy and expensive approval process for drugs imports. Also, that one can be considered as a kind of barriers to entry. And key important countries are also applying this kind of measure. And many countries doesn't have local pharmaceutical production system. So they rely on import, but the import is highly monitored, which doesn't allow a free access to the market of these various countries. And when it comes to, let's say, competition law enforcement, I think many of the rules adopted by the regulatory agencies are, let's say, not complying or not in line with what the competition authorities actually trying to enforce, because of the level of concentration, because of the protection given to the sectors, and also because of the high level of selective measures taken. After this, the outbreak of the COVID-19 at a higher level by the authority of a head of state, specific measures has been taken to, let's say, allow the few sectors of the various countries to be well equipped in protecting our populations regarding the fight against the outbreaks. And these measures actually is a discriminatory measure because it doesn't cover, it's not applied to all the companies operating in the health and the pharmaceutical sector. So, but what is actually worrisome for us as a competition authority, these measures that has been taken as exceptional measures to fight the pandemic of COVID-19 seem to be extended because it has been identified as a key important measure in the recovery plan that the region has decided to implement to, let's say, fight other pandemics that can occur. So it's a serious development because they are not in line with our competition rules. It's important for us is what we have been trying to do to discuss with national competition authorities as a regional body to try to fund, let's say, palliative measure that cannot be, cannot contradict what the same authorities have decided with regard to enforcement of competition rules. So it's not easy because the main concern raised is that this decision has been taken by the authority of head of state to, as a public interest, And how can this measure be, let's say, executed without a serious contradiction with competition rules? It's our concern, it's our main question that we have been discussing with our other national competition authorities. And so the regulation deficit actually is something that is clearly identified, clearly shown in many countries. But what is not helping the competition authorities, in one hand, you have a lack of regulatory. In the other hand, you can see that there are inflows of illicit drugs that enter the region, many countries. So I think based on that, you can see so many countries that have taken strong measures to stop the inflows of forbidden drugs. And it's difficult for competition authorities to go against this kind of measure because of the situation that has been always raised regarding the health care of in the various countries of the ECOWAS region. So I think I'm not going to be too long because I think the measures that have been taken by the authority of head state is something that is under negotiation. We cannot, let's say, go against it because it's a political decision. But our main action is to, let's say, discuss, is through dialogue, advocacy, sensitization, that we can come up with, let's say, concrete agreement, a common platform to be sure that the measures taken at regional level doesn't, let's say, affect the full and consistent implementation of the community competition rules. So it's an ongoing discussion, and I think with the various action that is underway, we'll be reaching to a common platform to, let's say, have a continuous discussion with the regulatory sector regulators to allow us to work on the same basis in implementing the various regulations for the welfare of our population. Thank you very much.
Thank you so much, Mr. Coffey. Thank you so much for setting the stage. You told us about the dynamics of the pharmaceutical sector, of course, very complicated. Now, with that, we come to our second speaker, Mr. Harbi Rachisusu, Deputy Commissioner, Competition Commission of South Africa, who's going to talk about competition and access in the healthcare sector.
Yeah, thank you very much. I had shared the slides with the organizers for both sessions, but I don't have a computer myself to connect. But I'll start if you don't have those. What I'm going to talk about, so the main session issue is on the regulatory deficit in access to healthcare. And I will then focus on competition and access to healthcare, share some cases from South Africa, essentially. I'll give some global observations, some basic facts about healthcare in South Africa, significant policy and enforcement interventions from South Africa to date. At least there are some few cases that we can share, and we'll conclude. Oh, you do? Yes, perfect. So I think just going with the theme of the conference, I think this theme is quite important. You can move to the introduction. And as we know, at least access to healthcare is not just a local issue; it's a global challenge. To see that in some cases there is access, but it's a very costly access, or there is no access at all. According to the World Health Organization, nearly half of the world's population still lacks access to essential health services. And over 800 million people spend at least 10% of their household budgets on healthcare. Access to healthcare to essential medicines remains a challenge, with an estimated 2 billion people lacking access to the medications they need. Entered, again, these are 2015, but these are still relevant studies, reports that the pharmaceutical industry is among the most concentrated sectors globally, leading to concerns about pricing, accessibility, and affordability. Not much has changed in the structure of this market, which then requires some intervention from competition authorities. Can move to the next slide. I've just flagged here this UNDP publication using competition law to promote access to health technologies. So it does cover a lot of cases. So this has recently been updated as well. Did record, I think, strides that were made in the HIV treatment, significant reduction indeed in the cost per patient per year, down from at least $10,000 to $100. At least this is now we're seeing some access possibilities. Parts in 2010 published a toolkit, and it does advocate for some adoption of uniform rules that ensure that firms do not abuse intellectual property rights and stifle competition. This is a toolkit that is quite useful. I think there's studies, South Center is doing a lot of work on this. As South Africa, we presented a paper, thanks to Teresa for allowing us to do this. We presented a paper on health, discussion on healthcare markets, access and affordability. That was a plenary at the IGE. And again, the message is consistent that there is a role for competition policy when you look at some of the cases that we have. Just let's proceed to the next slide. Some facts about South Africa. Of course, our constitution puts healthcare at the center. But the main challenge in South Africa right now is that we have a two-tier system, quite unequal. So the private sector and the public health sector, huge expenditure on the private healthcare sector, saving few of the population, whereas we spend more on the public healthcare sector. Or so sort of the amount of expenditure we spend on public healthcare sector is almost equivalent to what we spend in the private healthcare sector, but we save about 80% of the population in the public health sector system. So which says a lot about the cost of providing private health care. So you spend exactly the same amount of money for that. I'll do some cases. There is a case, ARVs. We had the same case early in 2003, settlements. You can see here, of course, there were these restrictions on generics by Boehringer and all of these companies, GSK. But after the intervention of the commission, we reached a settlement and they allowed, for generic entry, licensing and so forth, which saw sort of a tenfold reduction in prices. So this is a trend you see. We have some bid rigging case in pharmaceuticals, and it's picking up now. particularly in public health sector, because the procurement is quite huge for these drugs, and we have picked, this is what we prosecuted in 2008. We've started now to receive some bid rigging cases on these large contracts. We conducted a health market inquiry. I tried to explain this briefly just on how, but we had focused really on the cost of providing healthcare in the private sector. This was quite important because government has also been thinking about the national health insurance, which does depend a lot on the low cost of providing the services by the private sector. So that would be, you can move to the next slide. I'm trying to move quite fast here. You can skip the inquiry. You can skip the NHI. I just needed to introduce that. We had a case on PCR test kits in 2008 for COVID-19 in 2021. You can see there was a huge demand for tests. Pathologists in South Africa, again, it's mostly private companies. We do have a national laboratory service. It serves the public sector, but it doesn't have much capacity to deal with these new needs like PCR. So you had very huge price issues, and we intervened as the competition commission. I think that the test then with US dollar maybe 44, we reached a settlement that they dropped that by almost half. But that's just showing what competition can do. Looking at issues of excessive pricing. There's a breast cancer drug case on excessive pricing. You can move further against Roche. I think this is quite a familiar case globally. So this is currently before the tribunal being prosecuted. Then the last case, that's why I need to rush to this one, the Johnson & Johnson case, the recent issue on TB. There's a particular drug, is it bedaquiline? You probably know it better than me, that we had picked up, and we don't really take full credit here because there's been, I think, pressure from many sectors of society about this particular drug and the extension of the patent or undue extension of this patent. We did initiate an investigation. It was just timely, as there were to be discussions at the WHO, and what news is Johnson & Johnson announced that they will not be enforcing their patents, but only in 34 low and middle income countries. And one wonders why they would want to enforce. But this is something that it looks like it may be resolved. Our case is still open. Right. So I just point to some interventions we have there. Just in conclusion, I just repeat that our view is competition policy is one of the key, tools for enforcement that can be utilized. I think there's this debate whether in IP can we use competition law. I think there's been this discussion, but we do think you can. So not only when the IP has expired, but even when the IP is still active, you can still look into excessive pricing issues. So the issues that we focus on, as I've said, is excessive pricing, patent evergreening, and also bid rigging. And my last point, this is the last point in the slides, is that however in healthcare and for developing countries, domestication of TRIPS rules, especially these issues around compulsory licensing, could be the lasting solution. My country has not done this. Right? So the rules are there, but we see this, at least reading what India, and these are the experiences we would like to see, because I think India is really utilizing these provisions to the fullest. And that's why we see the kind of industry you have. So this is really the last point. And I think it's just to say competition policy alone may not be enough, but governments can also utilize, especially on healthcare, because it's quite specific. But I'll leave you to the experts on this particular one. Thank you very much.
Thank you so much, Mr. Rajesh Susu. I'm sorry I had to rush you. Your presentation reminded me of my PhD days, right? When I was looking at South African case law studies. So very bold, definitely your competition commission has been. With that, we move to Mr. Milind Antani, leader pharma and social sector practice, Nishit Desai Associates India, who's going to speak on price control versus competition. Over to you, sir.
Thank you, Vikas. I think I have slides, but I won't be using slides. So just request to organizers not to set slide deck. Just want of time, I will just try to finish off and don't give chance to Vikas to alert me at the end of 2 years. First of all, I must compliment the organizers for a very interesting topic. And I'm very happy that I'm seeing price control versus competition and not price control and competition. Now, if you see, and I think there's a shift in gears because we have been hearing on Competition Act and antitrust laws. But what I'm asked to talk is on how price control and competition go together, whether they go together or not. Interestingly, in India, entire healthcare system, I always call it a tripod, where one leg is affordability, second leg is accessibility, and third leg is safety. And on top of this tripod sits a beautiful camera, which is patient. Now, if you see competition, when we talk of price control, that is where the affordability element of healthcare system in India comes. And accessibility is another thing where possibly competition comes into picture. How companies promote their products, how companies make them accessible to the patients, or even make doctors aware to prescribe. But the most important element is safety, and safety is basically quality. Now, before I move on to really on price control and competition, I will also touch upon generally on competition, pricing and competition, a little bit on other topic as well. Now, it is said, I was just going through, what is competition? Oxford Dictionary says that competition is a situation where either two or more people or organizations are trying to achieve something, obtain something, either the same thing, or more importantly, to be better than somebody else. And from market point of view and from pharma point of view, I think here they are looking at striving independently for getting buyers' support to maximize profit. And what exactly we are looking at when it comes to pharma and healthcare, it's going to be always debated because we have a product-based competition, we have pricing-based competition. That is what we really want to talk here. But when you talk of Competition Act and price control, now before we move on to that, is competition advantageous or it is disadvantageous? I personally feel that competition is always gives an advantage, that because of the competition, the product in question gets better and better. As I mentioned, I want to do better than somebody else. But situation comes that when there is a price control, like we have a drug price control order of India under NPPA, which is an authority, the prices, all essential medications which are included into NLEM, which is National List of Essential Medicines, have a fixed ceiling price. And the products which are not included into the NLEM are called non-scheduled formulations. And there is a rule that the manufacturer or the company cannot sell those products which are not in NLEM by increasing price more than 10% of the price of the previous year. So there is a pricing. Now, does this price control mechanism, either fixing a ceiling price or not going beyond 10%, is really killing competition? Maybe yes, maybe no. The reason is that the biggest problem I personally feel, on one hand, of course, we want to give affordable medications to the patients in India. At the same time, we also want to give quality medications. With all due respects to all companies, I'm not saying that the products at the cost of price control or giving products at a lower price than the other competitor, there is some compromise with the quality all the time, but that possibility cannot be denied. And let me share. So when we talk of Competition Act, interestingly, in one of the cases, I think Ashwini Kumar versus Sun Pharmaceutical, let me just pull out what exactly the observation was. Okay. So CCI mentioned the determination of price of a drug and the aspects pertaining to its labeling. It was a case regarding labeling of the product. Labeling may not be in the domain of CCI. However, any unfair or discriminatory conduct in relation thereto by a dominant entity can be assessed by it, provided that the facts disclose a violation of the relevant provisions of the Act. So honestly speaking, having a price control and putting it versus competition, I would rather put it price control and competition and how they can walk together. Because when there is some issue on pricing, CCI would not come into picture, but when CCI observes certain things related to either positions or agreements which the parties enter into, whether they are vertical or horizontal agreements, I don't want to go into the technicality, or how the determination of prices happens. Now in position, the most important thing Competition Act looks for is abuse of dominant positions, whether there is a relevant market company is dominant and abuses that particular dominant position either exploitatively or exclusionary, where either they give products at a lesser price to consumer and different price to the distributor, or the price which is determined is price discrimination per se is not an issue, but when companies come out with a discriminating or discriminatory pricing becomes an issue. Agreements, as I mentioned, always becomes a challenge. If there is some kind of appreciation or adverse effect which is coming out from the documentation, then becomes a challenge. Very interesting thing which we have seen, not necessarily pharma, but medical device more, is the dual position of hospitals. Many times we have seen that products are sold to hospitals as a part of capital investments, whereas various products are given to hospitals as to be used in the patients, for which hospitals end up charging patients. So in these two situations, when products are given as a capital equipment, should not be a problem, but when it goes to hospital, which is again going to patients, may become a problem and may cause some kind of appreciable adverse effect, which may create a problem. I just talked about pricing practices. There are pricing practices that may, attract scrutiny, which we need to know is whether how discriminatory or differential pricings are offered to customers without any logic. There are exclusivity on pricing arrangements. There are loyalty discounts, bundling discounts, certain types of rebates which are given may pose a challenge from competition law point of view. So these are the few things I thought a company needs to know. Now, while we are talking about pricing and competition, now I'm moving on to Competition Act of India from law point of view. I being a lawyer, and I understood this because I was a surgeon for 14 years before I became lawyer 20 years ago. That there are certain factors that need to be considered, like, as I mentioned, bundling of products or exclusivity terms in the documents, assessing the market.
Mr. Antani, I'm sorry, you have just last 2 minutes.
Yeah, sure, I'm finishing it. Providing, monetary other incentives or differential pricing to consumers and distributors may become a challenge. So I think, what I would like to just end by saying that Competition Act, as I mentioned earlier in one of the case studies, case law, they observed that they do not have a kind of a domain to act on price control or price issue. But when there is, as I mentioned, there is abuse of dominance or appreciable side adverse effect, there can be a challenge. So end of the day, price control is here to stay. When I personally feel price control in India, on one hand, though makes products affordable, it may distort the market by killing the competition, I personally feel. So there has to be a guarded approach on price control mechanism in India, that the quality is maintained. At the same time, there is a competition, healthy competition amongst players in the market, so that better and less expensive products will come by default without price control. And as earlier mentioned, that antitrust needs to go out because there is no issue of having trust or not. So I very firmly believe that competition needs to be competition, where everybody needs to compete and cooperate together, so that you end up not competing with the rivals, but making them irrelevant, as it was mentioned in one of the beautiful book, Blue Ocean Strategy. So, Competition Act does not play a role in price control and other issues, but as I mentioned, it may create a problem if it is being abused. So I'll just end by saying one important line which I love, that it is said that at the end of the tunnel, always there is a light, but be watchful, it can be of a coming vehicle. So though there is no direct impact of competition law in pricing, but see that you don't end up abusing your dominant position. Thank you so much.
Thank you so much, Mr. Antani. Thank you so much for reminding us the virtues of competition in the pharmaceutical sector. With that, we approach the fourth speaker of the session, Ms. Archana Jadkar, Associate Secretary General, India Pharmaceutical Alliance. She's going to speak on regulatory barriers in pharmaceuticals, exports, and its impact on access to healthcare. Over to Ms. Jadkar.
Thank you, Chair. Can you hear me well?
Yeah, we can hear you. You have 10 minutes.
Yes, thanks so much. Thank you to the Chair. I just wanted to present this very brief introduction to the regulatory barriers. I know I heard the IP border measures as one of the topic, but I thought it will be a good opportunity to take forward and go beyond just the IP measures, but talk generally of the regulatory barriers that the Indian pharmaceutical companies face. First of all, I would like to apologize for not being present in person, but I would miss. I've been following the online discussions of the conference. I also would like to take an opportunity to cut thanks, and particularly CIRC for inviting us and giving opportunity to IPA to present its perspective on market barriers. It's a very timely topic. And I'd like to also take half a minute to actually introduce what Indian Pharmaceutical Alliance is all about. It's a industry body representing 25 leading Indian companies committed to patient care in India and across the world. Collectively, IPA members account for about 85% of R&D in India and about more than 80% of exports of drugs and pharmaceuticals, and services about 60% of domestic market in India. Our vision has been to make quality medicines available to patients at affordable price. And so the topic today is very close to what the pharma companies have been doing. Just before we get into the regulatory issues, I thought it would also be a good exercise to, outline where and understand where what is the contribution of the Indian pharma industry has been. The Indian pharmaceutical industry has been playing a vital role globally as well as for Indian economy. As you can see, we contribute about 20% of total global exports of generic drugs. We are third largest in the volume terms and 14 in value terms. While shaping the public health outcomes, the industry has been contributing to India's economic growth. Directly, indirectly, we contribute about 2.7 million jobs. We are also the sector which actually generates trade surplus for the country. And just to highlight the global contributions, I think it's important to look at, and I've seen in my previous speakers have been highlighting several cases of HIV, AIDS, and tuberculosis. I think Indian companies have been hugely contributing to this conversation. And as you can see from the slide, we contribute about 60% of global vaccine demand. We contribute about 30% of AIDS patients receiving treatment in Africa in 2009 versus 2% now that you have. Every third pill taken in US is a contribution from Indian pharma industry. Every fourth pill in EU is contributed by the Indian pharma industry. Having said that, I just quickly also wanted to remind you of the biggest humanitarian crisis that we went through and the enormity of it. In even those difficult, unprecedented times, it was the Indian pharma industry which showed resilience, which supplied medicines to over more than 200 countries. And also this was possible. What I wanted to highlight also is that COVID exposed us to a huge inequity that exists between the access and the availability of medicines. And here's where the Indian pharma industry has a lot to contribute, and it has been contributing. Coming to the actual discussions of, from a very trade perspective, Indian pharma sector, we've been contributing about the total exports for pharma products have been about $25+ billion for the last year. We are one of the critical sectors, and therefore it is important to look at the barriers faced by some of the Indian exports in key export destinations. Also, this is important from the perspective that India is undergoing a lot of FTA negotiations with regulated markets and a few more developing countries. While most trade partners have zero tariffs on pharmaceuticals, I think non-trade barriers or non-tariff barriers have become very critical. Now, just to give you a very quick view of what sort of market access issues are faced by the Indian companies, there are high cost of entering in the market. There have been cumbersome market authorization procedures. We have very strict IPR regimes. There are issues on government procurement side. There have been really divergent rules and regulations on the GMP certification that becomes very critical when we talk about market access in key things. Now, this is where I wanted to focus was when I say, we face so much of barriers, I thought I will categorize it into 4 categories. Really, there are many, as I've shown in my previous slide, but here are a few examples, where you have long drawn out market authorization procedures, you have really high cost of entering the market. There are overprotective or stringent price controls, and I think Milind is also pretty well versed with that. Giving you an example on what sort of market authorization barriers that we face, take for example in UK, we have each of our companies have to undergo double testing. This is a repeat batch testing within UK. Since India is not on the listed country of MHRA, every batch, when it reaches UK, all batches coming from India need to be tested. Although the MHRA has already audited, inspected, and approved the products as well as the facilities. This leads to really high cost and longer lead time. Just to give you a flavor, average batch analysis and batch certification would cost anywhere around 800 to 1,000 pounds per GP, and there are plenty of products that you export. The second, when you look at the high cost,
Ms.
you
Jadkar,
can
2
see from the
minutes.
slide.
Last 2
Yes,
minutes.
absolutely. Some of the really critical markets for Indian pharmaceutical companies have been US, and the biggest, I think, barriers that we face there are the anti-competitive practices through duplicative patents, such as this patent thickets, and product hopping, which are the causes of concern, not just for the pharma companies, but how do you make it accessible for the patients across. And a classic case for this is the extended protection to one of the medicines called Humira, which is used for the rheumatoid arthritis. Moving on, I just wanted to highlight a few regulatory challenges here. There are plenty. I've called out a few. One is the divergence in the national and regulatory frameworks. You have different varied pharmacopoeias for product standards. You have multiple reference product which are to be become a really important component when a product has to be introduced in the market. The product approval times take longer. There are multiple inspections conducted for the same facility by different regulatory agency. What are the solutions we are looking here? We're advocating for establishing a regulatory framework that allows convergence of requirements for assessment of generic medicines that will enable the industry to increase patient access. Can we use global comparators for the reference products? Can we have timely product approval, and compress the approval waiting periods? And that is possible. We have seen that in the COVID times. And can we have, in our FTAs or our bilateral arrangement or MRAs where the time taken is important for the patient accessibility? Also, can we move on to the next gen and look for remote inspections where a lot of time goes into inspections? So the whole idea of having a FTA or a multilateral or bilateral agreements, can they be helpful in striking this convergence that we are looking at? Here's what, the vision, a very quick vision I'll leave you with is, how can a global industry become a global contributor by achieving by exploring the new markets, by consolidating some of the existing key markets, and can we be the supplier of medicines which takes care of the patients? Indian industry has a strategic advantage of both scale and reach, and that's where I think the biggest contribution would come when we talk about affordable medicines for patient care welfare, not just in India, but across the world. So I'd like to end my presentation here, and I'm happy to answer any questions thereof. Thanks. Over to you, Vikas.
Thank you so much, Ms. Jatkar. It's an extremely important issue. I wish we had more time. So now we have Mr. Sameer Kulkarni, Head, Department of Biological Sciences and Biotechnology, Institute of Chemical Technology, Mumbai. Mr. Kulkarni is going to share his thoughts on regulation of biosimilars and its impact on competition. Over to you, sir.
So I was just saying that, I should take this opportunity to thank the organizers, and particularly Alex, who recommended me be joining this particular conference. I am kind of a fish out of water here. I am probably the scientist who has developed some of these molecules, particularly the biologics. And I'm going to speak about the business of biosimilars, impact of regulations on access. Access and probably also a bit on pricing. Now, typically I face this challenge because when I have to start educating, and now I'm also a professor officially. So to start educating people about what are biosimilars or biologics. Next slide, please. So what are biologics? I mean, typically large molecules like proteins, which are produced using living organisms or cells or their processes, with or without genetic modifications through controlled production. So, and when we say that these are large molecules, it just brings in that level of complexity into the overall development. And therefore, one of the important aspects to realize is when we talk about biologics, and not just biologics, even many of these complex pharmaceuticals. I mean, when I say complex pharmaceuticals, I'm talking about the small molecules, the conventional small molecules. Next slide, please. So this image, borrowed from the Nature article, that is Dr. Watson and Dr. Crick, who came up with the DNA model. And essentially this led to the overall revolution in recombinant DNA technology, using which lots of several life-saving products are actually now in the market, including one of the most commonly used products like insulin. So earlier, if you might be aware, insulin used to actually be extracted out of pig pancreas. So porcine pancreas, and then there were issues about immunogenicity and all that, and the complications were very high. Now human insulin is made in a host organism or in a separate cell, and then that is being sold or that is being used by the patients. So here's just how the progression has worked. So on the extreme left side is aspirin. You can see that aspirin about 180 Dalton. That's just the molecular weight. Then the insulin and other peptides about 5,800. Then about mid-size molecules like human growth hormone, GCSF. That's another hormonal protein. Erythropoietin. Monoclonal antibodies. Monoclonal antibodies about 150,000 Daltons. So basically, we are talking about a molecule which is 1,000 times larger than something like an aspirin. So when we say conventional pharma, we are talking about molecules which are very, very tiny, easy to manipulate, easy to work with. For a chemist, it's very somebody who is actually trained in the skill. It's very easy. But when we talk about a biologic, we are talking about a molecule which is extremely complex, very, very difficult to study it. There are very limited means to actually identify the overall structures, etc. Next slide, please. Now, these commercial biopharmaceutical products have been, since about the last 2 decades or so, they are being used very effectively in treating several complicated diseases. And many of them, they belong to the categories like monoclonal antibodies, hormonal drugs like erythropoietin or insulin, then vaccines. Vaccines I need not emphasize anymore because COVID-19 actually taught us what the relevance and critical aspect of vaccines really is. Then there are plasma fractionation products, cell-based therapy, stem cells. I'm sure many of you might have heard of them, and very recently gene therapy as well. Next slide, please. So these have been very effectively used to treat complicated situations like cancer, anti-inflammatory issues like arthritis or Crohn's disease, and those kind of problems. Hormonal, like I said, erythropoietin, which is used to increase the red blood cell counts in anemic conditions. Insulin for insulin-dependent diabetics, follicle stimulating hormone and other gonadotropins, which are basically the reproductive hormones, parathyroid hormone for osteoporosis and those kind of diseases. And now recently to cure genetic disorders, gene therapy products are also there in the market. Challenges. One of the major challenges is, like I have been emphasizing, that these are extremely complex and thereby very, very expensive. So look at some of the examples that I've just pulled out. The gene therapy products, look at the cost, $3.5 million per dose, $3 million per dose, $1.8 million. This is hopelessly out of reach for several, not just people, even countries. And this is where that major, aspect of biosimilars really play a role. Now let's look at what are biosimilars. Let's go further. Next slide. Yeah. So biosimilars, basically I like this slide because it gives a very, picture based understanding of what biosimilars can be. So let's take the example of aspirin. It's like, I'm trying to remake a bicycle. So basically, and then, if I take an example of something like insulin or GCSF, that's like, I'm trying to remake a Ferrari. And if I'm talking about a monoclonal antibody, that's 150,000 Dalton molecule. Here I'm trying to remake A380, the largest aircraft in the world. Now the risks are also similar. If you fall down from a bicycle, at the most you will break a bone. If you crash a Ferrari, other than the cardiac arrest that you would get because of the financial loss, perhaps you still might survive because Ferrari also comes with the safety features. And if you crash from a A380, absolute death. So the risks are also equally that high. And that is where basically to remake these drugs is much more complicated. Next slide, please. Now let us look at what these options of biosimilars really are. About 40, if not more, drugs are going off patent by 2030. And we are talking about a collective business that it can actually generate of more than $100 billion. And more than business, I think the most important aspect is that it can actually enable these drugs for access to so many different people by actually bringing in competition into this and actually bringing down the pricing of this. Next slide, please. Now, Indian industry, let's take a look at what the Indian industry has done so far. More than 90 approvals of biosimilar drugs have been there in the country so far. Why? Obviously, country needs these low-cost options.
Please, last 2 minutes.
Okay. Obviously, country needs these low-cost options. Technology know-how in the country is building up. Regulations are maturing up. And it's good for business. Next slide. Here's just a picture of how we have been able to achieve the drug price reductions. 90, 80%, etc. And this is what India has been able to do in the last perhaps a decade or so. Next slide. Now, this is just a process of how a biosimilar actually gets approved. Some of the major aspects here that I would like to just throw a light on are the process and analytical development part. Extremely complex, like I said, such a large molecule, one has to understand in and out about this because the risks are also that much high. And the regulations have actually got to run along with as and when the more and more understanding about these molecules is coming up. Next slide, please. Enabling access. Limitations. The drugs are inherently complex, like I said, and hence creating safe alternate options, biosimilars or follow-on biologics, is equally complicated. International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use, ICH, has laid down guidance on different approaches to ensure biosimilarity. However, still, pretty much all the countries have their own regulations and they are reviewing these particular things separately. And this is leading into a company, if they want to take a biosimilar into a certain country, each country they have to actually, and these are wide timelines. So the access becomes that much more restricted. Time consuming process leading to delays in availability of affordable options. Next slide, please. Now, how perhaps, this is one of my suggestions, how we might be able to address this. Grouping of nations with collective evaluations may reduce the time of access to cost-efficient biosimilars of quality standards. Perhaps countries can come together and essentially evaluate a certain molecule in coordination and enable access across the entire group of those nations. Because, like I said, the shared understanding, it has to increase. One has to start learning. Even the regulators have to be trained about what biosimilars are, and they have to necessarily start learning more and more about this. Randomized representations in inspections could be, randomized representations from the regulatory agencies into inspections of these organizations which are making these biosimilars can be actually very effective. Collective marketing approvals. So 3, 4, 5 countries coming together and approving that particular drug because they have essentially some sort of a pact or something and come together and approve the drug, and thereby enhancing the approach across the entire group. Developing nations particularly can leverage on the expertise of the developed ones. Like for example, India can play a very, very key leadership role here. Like I said, there are more than 90 approvals in India and about, I think, 10 to 15 organizations who have developed biosimilars. And a lot of options, a lot of learning can be transferred to the developing nations in this particular effort. Next one. This is where I stop and see one thing before I leave this particular dais. I would like to make a note here is that this particular pharma or biopharma domain is very, very high tech. One has to invest significantly. A new molecule to develop is somewhere around $3 to $5 billion. And it will be very futile to think that organizations are not going to really try and recover this. It's not going to be possible. The only way that it can be possible is by actually bringing in competition through these biosimilars and through even within the biosimilars creating competition. One of the case studies I would like to mention here. So rituximab, which is one of the molecule that is used for a type of blood cancer. So basically, this particular molecule, there was a case study done where the pricing was actually identified to go down, but the overall business was still increasing for all the organizations which were actually selling this drug, and that was because those many more people were using it. With this, I would stop. Thank you so much.
Thank you. Thank you.
And thank you,
Dr.
Vikas, for the extra time.
Thank you so much. And finally, we move to the last speaker, Dr. Lena. Dr. Lena? Not yet. Ms. Lena Meghani, whose task has become quite difficult. Many things have been spoken at the intersection of IP and access. She's Global IP Advisor, Medicine Sans Frontier, Access Campaign. She's going to definitely speak on pro-competition intellectual property policy. Over to you, Ms. Meghani.
Thank you so much. If someone can point out where my presentation is, that will be really nice. So I just wanted to highlight a few things. I'm representing Doctors Without Borders, Medicine Sans Frontières. And I was very pleased to hear UNCTAD earlier because, of course, we look at the guidelines on patentability as one of the constitutions in the area of intellectual property to be followed by patent offices. And of course, we have the South Africa Competition Commission here, and whose work has been a stalwart inspiration for a lot of us working on access to medicines. So just highlighting that when we talk about competition in the area of medical products, we're not just talking about medicines anymore. I mean, I would like to reiterate that we are talking about diagnostics, so tests, reagents, the whole algorithm of platforms. You're looking at treatments, but you're not just looking at small molecules. You're not looking just at generics. You're looking at biologicals. So, we discussed the whole issue of trastuzumab of HER2. It's one of the defining treatments for women with breast cancer. We did a lot of work in India as civil society. We are really pleased to see some of the work in South Africa. So just highlighting treatments not anymore restricted. People in the South have aspirations to be treated equally as much as in the North with these phenomenally interesting drugs called biologicals. And of course, you've got the vaccines, which you have the older platforms on vaccines, but of course you have newer platforms for vaccines. The mRNA platform, of course, is immensely. South Africa has led the debate on competition in the area of mRNA platform technology. So just highlighting that the balance between competition and IP is quite difficult because it's a trade-off that the IP system sort of created on the grounds that we would get more new innovation. So the red line is that if IP is going into areas where it's not leading to new innovation, competition authorities just need to step in. Or the other second red line, that if treatments are not equally available to poor and rich patients or to marginalized communities, then of course balance with IP must be created by competition authorities or those working on competition. Again, I would like to highlight that in the area of competition and IP, there are two major stakeholders that I would like to highlight. One, of course, the competition authorities and of course IP officers, but also the third stakeholder, which is silent, are patient groups. And if you look at the area of insulin, have done tremendous work highlighting how 3 companies are price fixing among themselves. So you can't do without the kind of information and knowledge that patient groups are bringing to the notice of authorities, including IP officers, but also competition authorities. So just putting all of those points forward. So I'm going to skip this. A lot of you all are familiar with Medicine Sans Frontières. And of course, it's one of the biggest procurers of generic treatments, but also increasingly of diagnostic tests and vaccines for the humanitarian work it does in over 70 countries. We set up the Access campaign as an area to bring in technical expertise and from different stakeholders, including patient groups, pharmacists, lawyers, and of course, disease specialists such as doctors who work in different disease areas. So that was the Access campaign. Next. So I just wanted to highlight, what are we talking about when we talk about IP? We're really talking about monopolies, that very dominant position that everyone talks about. You can remove patents and put in trade secrets, you'll still come to the same conclusion. If you can remove patents and put in data exclusivity, you'll still come to the same conclusion. You have one supplier who controls the market. You will not have competition. You will be importing the product and heavily dependent on those few concentrated suppliers. In most cases, you'll see a particular product is marketed only by one supplier, and they might prioritize certain lucrative countries over countries in the South. many other problems that we have with the market kind of dispensation in the area of pharmaceuticals. Next one. So, we've learned a lesson from HIV/AIDS. It started with Brazilians going into production for generic medicines, and the Thai is also starting to look at production of certain drugs needed for HIV/AIDS. And then, of course, Indian companies started to manufacture HIV medicines, which were found to be very useful for treating HIV at scale in other countries. And that's where the WHO pre-qualification system on quality was born. And of course, we had to look at intellectual property barriers and address those country by country. That is a decade and a half of work by competition authorities, patient groups, governments, ministries of health. And of course, today, you have treatments at around $50. I've stopped counting since last few years. It's just amazing to see the fact that, treatment for HIV is just a given. So if you look at the economics of it, once competition set in, you could treat millions in the South. And of course, many high-income countries now have started to, patients in high-income countries have started to talk about this model for themselves. For example, in the UK, where we need certain HIV medicines for prophylaxis, for preventive therapy, to prevent HIV in those who are highly vulnerable to acquiring the HIV infection. So these are issues that have been dealt with quite effectively through competition. And I won't go into the details, but the economics speaks for themselves. The statistics are there. We have more data coming out almost every year from Medicines Sans Frontières. Next slide. So what is impacting competition so dramatically? So if you're talking about IP, everyone just assumes it's innovation, right? What's actually impacting competition is the abuse of the patent system. We are not talking about therapeutic compounds or compounds that are adding to the therapeutic pool that you have for a particular disease. You're talking about an old medicine that's been reinvented in terms of process, formulation, combination, dosage, form, such as salt, crystalline, so on. And what happens is you have multiple patent applications and the threat of litigation, and you can very effectively block competition. Now, the case of bedaquiline is pretty much based on this whole issue of evergreening. J&J had a compound patent that expires in July 2023, right, Roshan? And they had another application on the same drug on the fumarate salt that gave them 4 more years of monopoly in South Africa. India rejected it, Brazil rejected it, number of countries on the process of rejecting it because patient groups had the right to challenge those patents in those countries. South Africa does not. So it automatically granted the patent. And that has led to the matter before the Competition Commission about the kind of pricing and supply that South Africa is facing in terms of a monopoly supplier. We'll go to the next. So what happened in COVID? I think we very quickly realized something that was very knowledgeable in the diagnostic sector, that actually trade secrets were a big problem for the South.
Ms. Meghani, last 2 minutes.
Yeah, I'm going to finish. This is almost my second last slide. So, we suddenly learned it's not just about patents. It's not just about extension of patents and evergreening. There was an area that no one had actually looked at since we signed the World Trade Organization's TRIPS agreement, which was trade secrets. Now, the trade-off at the WTO was that technology would flow to the South. It didn't happen because of trade secrets. And really, if you look at the competition matter that came up in Europe during COVID over reagents, a liquid buffer, you can quickly see that, the monopoly over the machine, the kits, the reagents were all tied together. And if hadn't been for the stepping in of the European competition authorities, Roche would have never shared the recipe. So you can just imagine, just by agreeing a matter or even issuing one statement, the competition commission authorities can force pharma companies to take action. So I just wanted to sort of highlight that. The mRNA platform issue has never been resolved because there was an outright refusal to share technology or IP on it. So that remains a very big issue that South Africa has led on and has constantly put on the table. And of course, mRNA technology is now being developed by countries in the South and parallel to the efforts that have been made by governments of Germany and the United States, who basically provided the technology to their own companies. and then allowed it to be monopolized. Lastly, I come to the issue of voluntary licenses. And this is really very important because everyone just views licensing and voluntary licensing as a very, very, very positive thing. Now, if you look at the licenses that are being signed, you will see China and India, there's a trend that's coming up. Countries where these products actually manufactured are left out of the licenses. Where you can source the API, there are conditions on that. So I think people should look much more closely at the voluntary licenses, both from the context of domestic production and domestic supply, and the countries that are being left out of voluntary licenses. One last slide, and that's it. So I just want to say that, of course, India plays a tremendous role in the supply of life-saving treatments. There was a moment in COVID where I think we paused because, there was this prohibition on exporting vaccines, and I think hopefully that will be addressed in the negotiations on the treaty. But I just want to highlight that Indian patent law has certain safeguards that protect competition. And the next one, and particularly Form 27. So if anyone wants to learn about the compulsory license experience, it's just based on Form 27, which is a statement on working of patents. It's a form that is attached to the Patent Act under the rules. And it is one of the finest documents on declaration and transparency that you can find in the Indian patent system. Unfortunately, it's going through massive dilution at this moment. And the last point that I wanted to make to everybody that, there's always this blanket exception for IP from competition law. And just to the last slide, if someone can switch. This is where the ray of hope has come from the South Africa Competition Commission, going back again and again to look at it much more, being very careful about, blanketly excluding views of dominant position based on IP. And this is where I just wanted to say this, that, by admitting the matter on Bedaquiline, on secondary patents granted on a few minutes salt, on Bedaquiline and extension of monopoly, forced J&J to rethink its strategy. And it came to the non-enforcement statement that J&J has issued. And of course, the Competition Commission will take a look at it. But what I want to say is this, that South Africa is leading the way on competition law. And the Competition Commission's openness to patient groups and public interest groups coming to it with these matters is really very important. And I think this is something that we really need to integrate in other jurisdictions. Perhaps, not just if India has looked at different ways of interpreting patentability criteria, we have to admit the South Africans are doing the right thing in the Competition Commission. This is where I would like to end.
Thank you.
Thanks.
Thank you so much. Unfortunately, due to the paucity of time, we can't have questions from the audience, but that gives you the reason to speak to the panelist over a cup of coffee or tea, which we are going to have just now. Thank you so much, all the panelists, those who are present here and those who are present virtually. I thank you for sharing your views on this extremely important issue, which was access, and innovation, like what Pradeep said, access versus equity in the healthcare sector. Thank you so much. Please join us for tea.